I am an anti-diabetic agent called Meglitinides.
My generic names are Nataglinide with a brand name of Starlix and Repaglinide with a brand name of Brendan. And this is my chemical name. I am classified according to my therapeutic and pharmacologic effect. Therapeutically, I am classified as the anti-diabetic, and pharmacologically, I am classified as amino acid derivative and meglitinide. Animal reproduction studies have shown an adverse effect on the fetus, and there are no adequate and well-controlled studies in humans. But potential benefits may warrant use of the drug in pregnant women despite potential risk. So I am categorized as C in pregnancy.
So now I am going to discuss about how I affect the human body, what the body do to me, what am I used for, my contraindications, my side and adverse effects, and what the nurse do to me.
My mechanism of action. I am based on the sulfonylurea moiety of a glibenclamide called meglitinide. I bind to the SIR1 receptor in the beta cell, although with lower affinity than sulfonylureas, and I stimulate insulin release in the same way. My other drug name, nataglinide, unlike the other me, repaglinide, has a greater effect on insulin secretion when plasma glucose levels are rising and, therefore, produces little stimulation of insulin secretion in the fasting state. I am absorbed orally and has a 56% bioavailability when absorbed from the gastrointestinal tract. My bioavailability is reduced when taken with food and my maximum concentration decreases by 20%. My protein binding to albumin is greater than 98% and I am primarily metabolized by the liver, specifically CYP450, 2C8, and 3A4, and to a lesser extent via glucuronidation. My metabolites are inactive and do not display glucose-lowering effects. 90% of me is excreted in the feces and 8% in the urine. 0.1% is cleared unchanged in the urine and less than 2% is unchanged in the feces. For the other me, nataglinide, I am rapidly absorbed following oral administration prior to a meal. My absolute bioavailability is estimated to be approximately 73%. My peak plasma concentrations generally occur within 1 hour of oral administration, and my onset of action is less than 20 minutes and the duration of action is approximately 4 hours. I am 98% bound to plasma proteins, primarily albumin. I am metabolized in the liver by hydroxylation followed by glucuronide conjugation. I am mainly metabolized by the cytochrome P450 isoenzyme CYP2C9 and CYP3A4. Me and my metabolites are rapidly and completely eliminated in the urine and feces after oral use. My average elimination half-life in healthy people and those with type 2 diabetes is about 1.5 hours. Indications. I am used to lower postprandial glucose levels because they are rapid acting and with a very short half-life. I am taken just before meals. Contraindications. I am contraindicated to patients who are allergic to sulfonylureas and other anti-diabetic agents, patients with type 1 diabetes, and patients who are pregnant and lactating. Side and adverse effects. For CNS, I can cause hypoglycemia, seizures, confusion, headache, and sudden change of behavior. For cardiovascular system, I can cause chest pain and angina. For musculoskeletal, I can cause back pain, arthropathy, arthralgia, and for gastrointestinal, I can cause diarrhea, nausea, constipation, weight gain, and dyspepsia. For respiratory, I can cause URI, cough, bronchitis. For eye, ear, nose, and throat, I can cause tingling around the mouth, blurred vision, runny nose, sinusitis, rhinitis, and for others, I can cause flu symptoms and accidental trauma. If you were a nurse, you should be aware of these responsibilities before, during, and after administering me to your patient. So, before my administration, you nurses should complete a health history of your patients, including their allergies, drug history, and for possible drug interactions. During administration, you nurses should monitor your patient's blood glucose levels regularly and HbA levels periodically to evaluate my effectiveness. Monitor carefully for signs and symptoms of hypoglycemia, especially during the 1-week period following transfer from a longer-acting sulfonylurea such as chlorpropamide. And insulin may be needed for glycemic control in patients with fever, infection, trauma, or impending surgery. After my administration, you nurses should educate patients about the risk of hypoglycemia and its signs and symptoms such as sweating, rapid pulse, trembling, confusion, headache, irritability, and nausea. You nurses should advise your patients to treat these symptoms by eating or drinking something containing sugar. The nurse should instruct patient to adhere to the prescribed diet and exercise regimen and explain the possible long-term complications of diabetes and the importance of regular preventive therapy.